All right, Chase, take it away. I'm only here for a few minutes. Unfortunately, I've been eating up. You guys see me walking behind JP. We have a lot of stuff in several rooms and other meetings that I have, but it's great. So take it away, Chase.
Good morning, everybody. If you guys didn't get the QR code or the text before we begin for the questions, it's right here. Listed on the slide here are all the wonderful team members who took part in taking care of the patient who we're presenting this morning. So our case is focused around a 52-year-old male who presented to the Mayo Clinic for evaluation of a known pituitary tumor. His story starts back in 2018 when he was involved in a motor vehicle accident. And following this time, he was just complaining of some generalized pain and fatigue. He saw several practitioners, chiropractic specialists, and nothing was really working for him. Eventually, in January of 2019, he obtained imaging, which revealed a pituitary mass. And he first came to the Mayo Clinic in February of 2022 to be evaluated for this mass. The first imaging we have on the patient is shown here. These are screenshots from a March 2021 MRI study. And at this time, the mass measured approximately 1.5 centimeters in its largest diameter. When he initially presented to us, his review systems was positive for generalized fatigue, frequent headaches, and lightheadedness. He had no other complaints. His past medical history was significant for benign prostatic hyperplasia and rheumatoid arthritis, for which he was taking hydroxychloroquine, and his physical exam was unremarkable. This is the first question. Gaetano stole my thunder here. What is the most prevalent pituitary adenoma subtype? A, non-functioning growth hormone acromegaly, prolactinoma, ACTH, associated with Cushing's disease. These are his initial labs from February. If Dr. McKenna wants to comment on these.
Yeah, so everything was within normal limits, no evidence of deficiency or hypersecretion. The only thing to note is that on previous outside labs, FSH had just been mildly elevated and that had normalized on the more recent labs. So the working or higher up on the differential was a gonadotroph type adenoma.
Thank you. This is a MRI study from December of 2022. On the right, this is T1 post contrast. And we can see that there is a enhancing intracellular mass. And here it measures approximately 2.3 centimeters in its largest diameter. And there's potential invasion below the intracavernous segment of the ICA. If Dr. Desai, anybody from neuroradiology or JP wants to comment further.
Yeah, stop there.
Right there.
Actually, JP, have Chase tell you where is the normal pituitary gland right now. Have him, instead of us telling him. And if he cannot tell you, then ask Diogo and keep going up the line. Huh?
I think the normal pituitary gland, you can see the pituitary stalk on the left. So
show us with your arrow. No, show us with your arrow in your computer.
Hold on. Let me work the computer.
And not just the stalk, and then the rest of the pituitary is going to be like a dome. So have him outline it.
I'm going to say this is the stalk, and this tissue right here is the pituitary gland.
Okay, maybe if you scroll your image a bit more, Chase. That's always a very nice exercise. Like here, the impression that I have, if you go back one slide, I think you should go to the stalk first. So I agree with you that, I agree that the stalk has shifted here to the left. And if you scroll a bit more, I disagree with you here. I don't think that the gland is here in the top. My impression is that the gland is thinned out here towards the left side. That's the impression that I have. I don't fully remember this case right now in my mind, but being pushed towards the upper left corner. That's the impression that I have here.
And have him scroll, because I thought I saw it. Have him keep scrolling both ways, both sides. Keep going. All right, keep going the other way. Keep going, just to see. All right, I agree with JP. It's tough. This one is a little bit tough. At least you can see the stock very well. But based on the stock, it tells you more or less which way it's going to be splaying. It's just like a dome. is going to be right there in that region. And sometimes you can actually see it better in the sagittal. Look at the sagittal. Let's see. You learn how to look at these things so that way you can go look back and forth. Yeah, the stalk. Yeah, keep going. Just play with it slowly but steadily, probably right there. Yeah. And that's probably it right there. That one right there, the one that you had before. If you look at the top right there, that thin layer, maybe point it out, JP, with your drawing right there, that thin white, there you go. That may be it. But this is it. It's going to be paper thin, but it's going to be there. So, we may see it when we are doing the surgery soon in the video. So anyways, good.
And then the other thing that I just like to highlight here, Chase, is the cavernous sinus on the right side again. Okay, stop right there. Perfect. You see, this is the horizontal segment on the right side, and then this here is the adenoma that we see here, right? So this extension here, or so at least the impression that we have. So differently from the other case, we have now this component extending below the carotid, below and medial to the carotid, and we have this area here. So despite the, and this would be therefore per classification a 3B NOSP score. So inferior, not superior as the previous case. What is interesting in this case is that if we look at this white, component, the hyperintense component that you have here, there is a possibility that some of this will just be displacement of the medial wall rather than actual invasion. However, 3B, when you're seeing the image, is always more likely to actually have a real invasion rather than so than the 3A. So the 3A, if you see that, and if there's questionable invasion, quite often it's just pushing the medial wall. The 3B, for some reason, maybe the medial wall is just thinner in that area. It is more likely to actually have a real invasion of the cavernous sinus in that component. Anyways, let's keep going. Let's see what we can observe in the next images and slides.
And here's the T2 image. And again, we see the same mass. And the cavernous ICA looks patent bilaterally. Anything else, JP?
I think you're muted, JP.
I can go back if he's muted.
No, I was just saying that, I'm sorry, I was muted. I was just saying that nothing much to add, but what we had just discussed and the heterogeneous MRI appearance within the tumor. So if hyperintense areas would suggest that this is a soft tumor, like 90% of the pituitary tumor should be, and therefore we would expect this to be resected in an expedited fashion, kind of using similar techniques as we did in the previous case.
And we obtained CT sinus for operative planning. I don't believe anybody from ENT is on the line. But here in the sagittal plane, we can see that there's well minimization of the sphenoid sinus. And in the coronal plane, we could see one septation in the sphenoid sinus, and there's a right septal deviation, rightward septal deviation.
Yeah, I mean, I just because she has a beautiful anatomy, it's always good to have like a go back. We're gonna do a quick review. Stop there. Yeah, don't move. Okay, so let me see here who I'm gonna choose. This is gonna be like a bit of a anatomy review here for this. So who am I gonna pick up here? Okay, I'm gonna start with the fellows. So let's get Carlos. Are you here?
Yes, I'm here, JP.
Okay, wake up. So good morning, Carlos. Always
Morning.
good to see you. So what is this here?
So that should be the optic canal, if I'm not mistaken.
Yes, right. That's the optic canal on the right side. So this is the
Left optic canal.
beautiful. What is located lateral and superior to the optic canal? What is this piece of bone right here?
That should be
the anterior clinoid process.
Okay.
Okay, on the right and on the left. So the optic canal is going to be located inferior and medial to the anterior clinoid process. Okay, and then here, if we follow this, and then of course this is the planus sphenoidale, and then if we follow this, the lateral wall of the sphenoid sinus, we're going to see this little hole here that has another one right here. Diogo, what is the name of those spaces there that I just marked?
I was gonna say, is it foramen rotundum?
Foramen rotundum, exactly. And that's always the reference. So that's the space where V2 gonna go through. That marks the floor of the middle fossa. Okay, and then medial and inferior to foramen rotundum, you're gonna have another foramen that is very small, another canal that we can see right here. Do you know what that is?
Is it the foramen ovale?
No, foramen ovale, you can't see it like this. It doesn't look at you. I can show you in a second. This is the Vidian canal. Okay, so that's important to exactly. I see Jeremy just answered Vidian canal. Okay, so this here would be the pterygoid process. Sometimes this space is pneumatized, and you got this area here, which would be the lateral recess of the sphenoid sinus. In order to continue with time, scroll a bit the images just so I show the foramen ovale. Go the other way around. More. Okay, stop. Back. There. So this is foramen ovale here. Right here. Okay, so foramen ovale doesn't look at you. It's it's perpendicular to the plane. Okay, let's keep going. Beautiful work.
Okay. And next question, what is not a structure within the cavernous sinus? Okay, try to save some time, so I'm going to keep going. This is from the same paper that Gaetano mentioned earlier from Dr. Almeida. I thought it would be quick to just talk about the inferior compartment since there's potential involvement in this case. The yellow depiction here is my crude outline of where this space would be. The inferior compartment's boundaries are it's anterior to the short ascending segment of the cavernous ICA. It's inferior to the horizontal and anterior genu subsegments of the cavernous ICA. And laterally, it's bordered by the lateral wall, and medially, it's bordered by the medial wall of the cavernous sinus. The middle image, we can see one of the important structures running through here, which is the abducens nerve. And on the left, we have the internal carotid plexus. And the right image is a nice view from looking at it from an inferior aspect. Dr. Amita, is there anything you want to add?
No, very good. Please, and go ahead. Yeah.
Okay, so given the patient's lab results, his age being over 50 in a male, the most probable diagnosis is a gonadotroph type pituitary adenoma that's non-functioning. Other differentials are listed here. So to recap, this is a 52-year-old male with an enlarging presumed pituitary macroadenoma, which now measures 2.3 centimeters with phosphoric cavernous sinus invasion. Given the large size and girth of the tumor, he was offered a endoscopic endonasal transsphenoidal approach to attempt coastal resection and prevent potential visual field losses. Other options for him included observation and continuing his serial imaging, stereotactic radiotherapy, and other surgical approaches. Intraoperative complications are listed here, and some postoperative complications are also listed, notably potential for a CSF leak and hormonal imbalances. And here's the operative video. Here we could see Dr. Donaldson lateralizing the middle and superior turbinate. And she does this bilaterally. This is in the patient's left nares. And then following this, she opens the sphenoid ostium. And here she's harvesting the nasoseptal flap. And she's elevating the flap off the septum. And she's resecting that inferiorly, where she will store it in the nasopharynx for later use in the case. And here she's removing part of the cartilaginous septum to get better exposure to the posterior septum. And then here she's just removing some of the mucosa. She performed an inferior turbinate reduction bilaterally to improve the nasal patency to the sphenoid. In this case, she did it bilaterally. It's just being shown here in the patient's left nares. And then now she's drilling down the kill of the rostrum and doing the sphenoidotomy. She's removing some of the inner sinus septations. And then extending it laterally. And then just drilling it down again.
Okay, so after that, beautiful work and exposure was achieved, then we go into the sphenoid and then the skull-based phase of the procedure. As always, first part is identification of the anatomical landmarks. After that, we're gonna be drilling and then roofing the sella, following the same steps, diamond drill, a circumferential dissection, and then we can further expand, just removing the thin out bone, going to the edges. In this case, once again, we don't need to have a maximum exposure on the left cavernous sinus. We do want to have exposure, at least partially of the anterior wall of the right cavernous sinus, so we can at least explore partially that inferior compartment as needed. So that's what we're doing there. And then after that bone is partially removed, we can map the carotid on the right side with a Doppler. Once again, cruciate opening in a similar fashion as demonstrated in the previous case. So I particularly always follow that same principle. So it's almost like a repeat. As you see, the steps are very, very similar. I always cut in a inverted V shape, round knife, and scissors going in the other aspect. That gives you this, panoramic view of the adenoma. And once again, you see that this one was also a soft tumor, such as most pituitary adenomas. And then we can mobilize the inferior part, clean all the way to the end part, which will be the dorsal sella and the dura covering the dorsal sella. And then we're going to be cleaning and exploring towards the left side first to try to identify the normal pituitary gland, which we expect it to be on the left in this case. But first we will see the medial wall of the cavernous sinus. And then as we clean the left side, we're going to start to find some normal tissue here, normal tissue of the pituitary gland that will be more easily observed once we clean this tumor. So I can see already the plane of the normal gland that is here, and this tumor on the left side has been cleaned. So what you see here is some diaphragm that was falling down already. So I need to stop touching the left side so I can open the anterior wall of the cavernous sinus with a feather blade. That's what you see right here. And then we're going to start exploring this inferior aspect here. So you see some tumor that was occupying this inferior segment or inferior compartment, so to say. And then this is the tumor here that we have to remove, such as the MRI had demonstrated. So using now, once again, the Castelnuovo dissector, we can go and work with our suction and with our angle curettes, using the angle curettes as a dissector, much more so than a spoon to clean the tumor. That's a very important anatomical and technical nuance. So now with two suctions, we can clean that space and we can get all the way. What I'm touching now already is, this is some of the medial wall that was sealed there. And I'm just gonna transect that so we can get the horizontal segment of the carotid better exposed. You see that we still have some residual tumor in the upper right corner, which we have to clean, of course. And of course, this is the work, is to clean that tumor while try to minimize the CSF leak, which we can have. It's not a problem, but we just want to have if necessary. So here you see exploring that right left corner, upper left corner, I'm sorry. And then we see that that's all clear. The gland is here. And then we're going to further explore the right corner. And we're going to bring endoscope in a moment that is going to facilitate. So you see that there is no more tumor here. We can see the horizontal segment and the vertical segment here already. And you see that you can, maybe in a second, we're going to be able to stop. I'll let you know. Just be prepared to stop the video in a moment. Next, it's okay. You can go back a bit just so I can show something. We had that at the time that I'm coagulating. Back. Okay, there, maybe. Okay, here we had the horizontal segment, and here we had the vertical segment. In the carotid, we'll be doing this, right? And this is there that we clean. After we clean the tumor, you can see that the lateral wall starts to prolapse towards us, and then here this area is clean. So this is the diaphragm. This is the normal pituitary gland here on the left. So at the end of the surgery, what we aim to achieve is to expose all of those anatomical structures that we had identified preoperatively in our MRI. So it's basically achieving those goals. So we can go back to the reconstruction now. And in this case, the reconstruction was performed with use of, I just place a layer of a gel foam inside the cavity and biodesign and then a flap.
And unfortunately, the video cut off. The recording stopped in the operating room before we could see the flap placement. But here's Dr. Donaldson elevating the flap from the nasopharynx to prepare its preparation.
Which is good. Perfect. Let's see what happens afterwards, Chase.
Okay. And then we have the pathology. Dr. Gentoff, do you want to comment on this?
Oh, yes, it's a very similar to the last tumor, a very monotonous cell population. You can see some perivascular orientation, but not as much, but it has the same look, almost exactly same look as the last tumor. If we go to the next slide, it has the same staining pattern as well, has the transcription factor SF1, which is consistent with the gonadotroph, and it has scattered FSH positive staining cells. They weren't very strongly staining, but they were definitely positive and scattered throughout the adenoma. So it's a gonadotroph type adenoma. There was no increase in Ki67 labeling in this case. It was between 1 and 2%.
Thank you, Dr. Gentov. On the left is the pre-op image, and we can see the mass. And on the right is the T1 post-contrast. We can appreciate a gross total resection. Any comments, JP?
No, I mean that looks fine. Like we can see here, the external resection, see the Meckel's caves that are in the lateral part. Of course, there was no tumor there. You can see Meckel cave here, Meckel's cave here. The pituitary stalk that was to the left, the residual pituitary gland on the left side. You can scroll. And then basically the resection cavity with the medial wall moving back to the original location. And here we had placed the gel foam and Surgicel. You obviously see a bit of that. So as you said yourself, our impression is a gross total resection here in this case, and very, very nice case.
Okay. And this is the sagittal plane. Preoperative on the left, and I'll let the post-op play through on the right. And again, we can appreciate a gross total resection. T2, let it play through on both sides.
Yeah, the T2 and the post-op, it's really, really useful because of the post-op changes, but that's good. Okay, let's see what happened clinically.
Okay. The patient recovered really well. His post-operative course was pretty uneventful. On post-op day 1, these are some of his labs listed. I'm sure Dr. McKenna will comment on the next slide on those. He was discharged post-op day 1 with follow-up with neurosurgery and endocrinology. Post-op day 14 was his follow-up with neurosurgery. He was doing well. He did have some loud complaints of smell and taste disturbances, but other than that, he was healing well and happy. And we have follow-up imaging for him scheduled in 6 months. Here are his follow-up labs if Dr. McKenna wants to comment.
Sure, yeah, just as Chase said, everything was within normal limits. Cortisol was definitely above 15, so no need for steroids at discharge. And his sodium looked good. There was the urine osmolality on the previous slide that was a little bit low, but again, no evidence of hypernatremia and no polyuria. The patient did well.
And this is just the paper that Gaetano and myself had in our presentations from Dr. Almeida for anybody wanting to get a little bit more reading in the anatomy and different surgical approaches to the cavernous sinus. It's listed here.
Thanks for sharing that. And I'd like to open up for some comments. We, we're blessed to have a lot of people from, many different places here with us today. And I'd like to invite maybe Dr. Hakeem and Diogo, Dr. Gomez from Colombia, to share some comments if they would like to, of course. I don't know if Dr. Hakeem or Diogo are still here with us.
I'm here. Yes, we're here. Hi, how are you?
Good morning.
Well, JP, when I see your cases, what we concluded here with Diego is that you know so much anatomy that you can just just go around every part of the anatomy perfectly. You can show us, a lot of things that probably most of the neurosurgeons wouldn't do. Many people would just go in, normally open the dura and just with a curette take out the most part of the tumor, or at least probably all of the tumor, but it's not always feasible. But with the techniques that you're showing us, opening the cavernous sinus and going in and taking those small parts of the tumor, especially if it's a functionating tumor, that will make a big difference in the state of the patient after surgery. So that's actually what we learned, that we can do those things as you're showing us, and just congratulate you. And we're waiting that you come here and teach us all of that.
Thank you, Fernando. I appreciate
welcome.
that. And Dr. Hakeem, thank you very much for your comments. I really appreciate that. It's like in my opinion, this is all a result of a teamwork. We're just blessed to have a great team here at Mayo, and that allows us to do this and achieve the goals. And I think that the anatomy, it's always the pillar stone for all of this. So without anatomy, in my opinion, we cannot achieve those results. So I think that this philosophy of incorporating everything we do into anatomy and anatomy into everything we do makes a lot of sense, and I think benefits our patients. And then finally, I think it's also bringing the tools that we use in microsurgery, in cerebrovascular and skull base into pituitary surgery, because in the end of the day, those are the usual microsurgical techniques that we just should be applying and trying to incorporate more of that. But I agree with you that does benefit patients, especially so the ones with functioning, but also so those, I think, young patients like the ones we had today with the non-functioning pituitary tumor. So thank you for your comments. And yes, I'm fully prepared to go to Colombia. So I'll see you very, very soon. Thank you.
Very welcome. Welcome.
Thank you. Okay. Anybody else would like to share some comments? If not, I want to be respectful of everybody's time. I'd like to thank Dr. Sampson, Dr. Chang, all our endocrinology team for the meeting today. And I'd like to thank Chase, beautiful presentation, Gaetano as well, Diogo, Andrea. And Diogo, you want to share what we have for the next sessions?
Sure. So we won't have the lecture series next Monday. We'll have an all-staff meeting. We'll be resuming on the 23rd of January with Dr. David Harder. He's coming from NYU and he'll be talking to us. So join us in 2 weeks. Thank you, everyone.
Thanks, everybody. Have a very nice weekend. Bye-bye.